All right.
Okay. All right. Well, thank you all for joining us tonight. I'm Sarah Sawyer here with my husband, Greg Nemitz. Our daughter, Ella, is a fourth grader here at EB, and we're happy to be chairing the new Learning Differences Support Group at EB and excited that you're all able to join us for this important conversation tonight. Our daughter, Ella, just briefly was diagnosed with a learning difference over the summer. And in addition to processing all of the emotions that go along with that, we also learned how important it is to have a collaborative team of experts and friends and family around Ella to support her emotionally and academically. Our speaker tonight is Nilofar Sami, a clinical psychologist with over 10 years of experience in direct mental health settings and 15 years of experience working in research programs with children and adolescents. Dr. Nilofar Sami obtained her doctorate degree from UC Berkeley with pre- and postdoctoral training at UCSF. In addition to working with children and families, Dr. Nilofar Sami leads professional development workshops for mental health service providers, as well as elementary and secondary teachers. Tonight, Dr. Nilofar Sami will be discussing the broad spectrum.
Sarah, you muted. You're muted.
No. Oh. And how to manage a child's therapeutic and educational next steps when faced with the neurodiversity diagnosis. So won't you all please give a warm welcome to Dr. Nilofar Sami.
Dr. Sami, just go ahead and unmute yourself.
There we go. All right. Thank you. Good evening, everyone. I want to say thank you for joining us for this discussion around neurodiverse children. And our conversation this evening will be around thinking about assessment, actions, plan, and developing a team approach to working with children with neurodiverse challenges. I appreciate the Learning Differences Support Group for inviting me here this evening to have this conversation with the families. And I know how challenging it is when you have your children at home and it's right around dinner time. So I appreciate everyone being here. I will do my best to cover as much as possible. It's really a broad area of conversation. So we're not going to be really drilling down for depth, but more looking across. But my understanding is that the team will be looking for other professionals who can then drill down for depth around assessments and understanding learning differences and challenges. So tonight's conversation is really a more broader conversation. I start things going. I'm going to see if I can, looks like okay, here we go. So before we start, I know each of you is here because you may have a child that you're concerned about or that you're interested in learning more. But before we begin, I want you to think about that child and the reason that you're here tonight, that you've joined this conversation. And think about what are your aspirations and dreams for your child, this particular child of yours that you've joined this session tonight. So I'm going to give you a couple of seconds to think about that, your aspirations and dreams for your child. And I want you to think about this particular child of yours, their strengths and their interests. And I'm sure that they have many strengths and interests. So think about those. And now for that same child that you're holding in mind, I want you to think about their main difficulties, the challenges that they're experiencing, things that worry you or concern you. What are those challenges? And it's important to hold that in mind as we're going through this conversation. So Tonight, I'm going to be kind of looking at across 4 different areas, domains of development in children. These are not all inclusive. There are more domains of development than what I've put on here. But these are kind of the main areas that we're looking at that may be impacted by neurodiversity. And also what we're using as a marker to look at between neurotypical children versus neurodiverse children. And the 4 main domains of development that we're going to be looking at is movement and physical domain. So we're talking about the gross domain. These are, the arms and the legs, the movement that allow for, the smooth coordination. These are things that, as we look across development, children by this age, so between the ages of 5 to 11, are starting to really master and participate and enjoy participating in sports and joining competitive sports. And they're also the fine motor domains. These are kind of the fingers and hands, used for drawing and creating and cutting, forming letters and writing letters. So those are the movement in the physical domains. Then we move into the language and communication domain. So at this age, we're looking at receptive language, kids understanding what's being shared, what's being taught within the classroom. It's also looking at, kids being able to hold 3 to 5 step directions, whether it's from parents or teachers or from sports coaches. 3 to 5 step directions, holding that in mind as they're executing each one, the order that they were given. We're also looking at, within the language and communication domain, expressive language as well. The ability to be able to express their needs and, inform the sentences in a coherent manner, as well as reading. And then we're looking at the cognitive domain, where it takes learning and thinking and problem solving. So as the kids are getting older, they're able to engage in more abstract thinking, more problem solving. They're more curious and asking questions and learning things. So we should be seeing this and how they process this and how much they hold things in their short-term memory before it gets inputted into the long-term memory. And then it's a social emotional domain. As kids in this elementary school age range start to really have an increased interest in peer relationships and developing those and actually playing interactively and problem solving, they're more aware of their social status and how they're doing. So these are kind of the 4 main domains that we're going to be looking at. As we're having a conversation about how these domains are impacted by, the neurodiverse child experiences. I'm going to skip these in the interest of time in terms of kind of defining those. I've just gone through it a little bit and given a little bit of a brief explanation. And these slides will also be posted by the group. So you guys will have access to it to go in a slower way if you wanted to. So what is neurodiversity and what do we mean by this? Well, the term was really coined in the 1990s. It's really appreciating, that there's a continuum in brain development and functioning. And this continuum goes from anywhere from a neurotypical child in the domains that we talked about to a child that's neurodiverse and can have a lot of strengths in certain areas, but also challenges in some of the other areas. And this is also an umbrella term that's used that includes many different diagnoses. So these are, it includes kids with attention deficit hyperactivity disorder, children with autism, who are on the autism spectrum, kids with learning challenges, disabilities, dyslexia, dyscalculia, and dysgraphia. It's looking at children who have sensory processing challenges and Tourette's syndrome, to name some. Again, this is not all an inclusive list. But neurodiversity also acknowledges that given the strength, there's also these real challenges that kids are experiencing and that these are really lifelong challenges. So these are challenges that, kids don't usually grow out of. They learn how to manage and they learn how to deal with it. And they learn how to work through it, but it's not something that they grow out of or that's cured. And so I want to kind of talk about a couple of different areas of diagnosis and prevalence rates. I want to explain what a prevalence rate means because, I'll be sharing some of the different diagnoses and that word will come up. So I want to make sure we all have a common understanding of what that means. Prevalence is really the number of people in the population, so the number of kids in the population that have that particular diagnosis out of all the children in that population. So that's the prevalence rate. And so, for example, when a family comes to me and says, we've been getting feedback from the teacher, my child has a hard time sustaining attention in class, or maybe blurting out answers, or is being impulsive, or is moving a lot. We're not sure. We may think that, he might have ADHD. And so this is where I, as a clinical psychologist, will do the assessment, and what I'm looking at is what are the symptoms that the parents are seeing and have heard that are present, and what's the severity level of these symptoms. I also look at the onset. When did these symptoms come to be, and that the parents are seeing, and the duration of it. How long have they lasted or, going on? And I'm also looking at this across settings. So not only am I asking parents a lot of questions and having them fill out questionnaires, standardized questionnaires, I'm also meeting with teachers, seeing what they see within the classroom. I'm meeting with the child, him or herself, and trying to get an understanding and have observations. So I'm seeing how these symptoms, are they first present across all settings? And second, if they are, how do they get displayed across settings? And that's important to understand. And then I look at also at the significance that these symptoms are causing, the distress, the impairment level in the area of social, academics, and family life. And so this is what clinical psychologists do to kind of, when a family is coming in with a particular concern, around ADHD, it could be around autism, it could be around anxiety. So any of these concerns that they may have, this is what clinicians usually do. They do their clinical evaluation in such a manner. Now, for more detailed assessment, we'll talk more later at the end around learning challenges, Zahira's learning disorder. These are really questions that a neuropsychologist assess, or school psychologists who do a lot of this assessment, which involve a different array of testing and training around. And so I would not be diagnosing and assessing for specific learning disabilities. However, in my practice, I do look at, are there things that are coming up that may kind of have a hint that the child who's actually maybe frustrated and upset at certain things, that there may be actually a learning challenge. So this is where I encourage parents to get an assessment if one has not been done, to really figure out if this is something that's going on. So let me, I do a lot of work with kids with ADHD. So I want to kind of, from the neurodiversity perspective, really, look at the strengths that the child comes in. And this kind of goes back to the initial slide when I had you guys think about not only your aspirations, but what are your child's strengths and interests that they have. ADHD itself, it has a lot of amazing assets. When children find activities or reading that they're really interested, they can become hyper-focused. They can sit there for a couple of hours and really hyper-focused on that activity and keep going. They have lots of creativity and curiosity. There's a lot of innovation that children with ADHD display. Leadership skills. There's a lot of high, amazing amount of energy level and spontaneity and productivity. So there's a lot of strengths, and that's important for kids to know that about themselves, if this is the neurodiverse diagnosis that they have. But on the flip side, it's also important to stay real and acknowledge the challenges that some of those symptoms bring. And these challenges include difficulty focusing and sustaining attention for long periods of time, listening and following through on directions, difficulty organizing tasks and activities, initiating and completing tasks, getting easily distracted and forgetful of just daily routines. So remember the 3 to 5, asking a child to do 3, step instructions or 5-step instructions. This is really hard for kids with ADHD. So even though it's developmentally normal by this elementary school age, for them, it could still be very, very challenging to do this. And these are just the inattentive symptoms. There are also children who display the hyperactive impulsive symptoms. And these include fidgeting, with hands and feet, squirming in their seat, real significant challenges being able to sit in their seat for 10 minutes or longer. So running around, climbing things, excessive energy, talking a lot, interrupting, blurting out answers, butting in on conversations, having a hard time waiting their turn. These are significant challenges that impact the child, not only socially, but also impact them academically. And so for ADHD, really, there are many different factors that put a child at risk for developing this. There have been 20 different genetic studies that have shown that it's very heritable. So if a parent has ADHD or ADD themselves, they're more, there's a higher chance that they will actually have a child who will develop these challenges as well. There's exposure to environmental toxins in pregnancy or during young age, such as lead. There's studies that have shown consistently that alcohol and tobacco during pregnancy is a high risk, for developing a child with having a child born with ADHD, as well as premature delivery and low birth weight. So none of these in and of themselves alone always cause, a pregnancy to lead to a child with ADHD, but they increase the chance. There are 3 subtypes of ADHD, and they're the predominantly inattentive type, which I talked about. And there's the predominantly hyper and impulsive. So they mostly meet the criteria for having a lot of energy and impulsivity and fidgetiness. However, it doesn't get in the way of them being able to focus and sustain attention. And then there's a combined presentation where they have both the inattentive and hyperactive symptoms. So this is the prevalence rate for ADHD in school-age children is between 9.4 to 11%. So the way I usually explain it to families, I say if you have a school full of 400 kids, well, if it's about 10% of school-age children, about 40 of those children are displaying or have already been diagnosed with ADHD. And so that means a child could have, a teacher could have 1 or 2 students in their classroom, and they may have different subtypes. More boys are diagnosed than girls, and ADHD also co-occurs, very likely co-occurs with 9 other conditions. For example, kids with ADHD, 20 to 40% also develop anxiety. There's about 20 to 60% also have learning challenges. They can develop depression later on in life. So there's other co-occurring challenges that can also be present for a child with ADHD. So it's important to really comprehensively assess across to see what else might be going on as well. Now I'm going to again, we're going for breadth here and not so much depth. So I apologize if I'm going too fast, but hopefully you'll have questions and you can ask me during the question and answer portion of this discussion. The next piece is the autism spectrum, children with autism spectrum disorder. We're on it. Again, a lot of amazing strengths. Average to high average intelligence, really high verbal skills and a rich vocabulary, ability to sustain attention for long periods of time, very detail oriented and can have really novel solutions to challenges, and really able to retain large amounts of information when it's provided. However, on the flip side, children who are on the autism spectrum disorder, which is another, challenge under the neurodiversity umbrella, is that there's persistent deficits in social communication, social interaction. And what that means is, they have significant challenges in social emotional reciprocity. So when they're interacting with peers and adults, there's a give and take, right? I share my interest, I listen to yours, I ask questions. That is, that's a significant challenge for them. Nonverbal communication. So as we're communicating, it's not only the verbal, but our brains are indirectly also scanning for nonverbal communication. This is looking at the tone of voice, how fast it's going, the way the person's standing, the way they're looking. We use all of that, and 70% of communication is actually nonverbal. So we not only take the verbal, but we map on the nonverbal to really hear what that person is saying, how they may be feeling, and get a sense of the interaction. Well, kids on the autism spectrum have significant challenges in that area, as well as developing and maintaining and understanding relationships. So friendships can be quite challenging. And while they have, really amazing interests, it could be really restrictive and repetitive. And so that they can super focus on certain areas and really have a hard time when peers no longer want to talk about that and shifting over to what the peer's interest is. And for autism, again, there's multiple factors that could, increase the chances of a child having ASD, and genetics is one. So there's a family heritability. So that's why it's important when a clinician's actually doing an assessment, they're also asking for a family history, just to see, are there family members diagnosed or not that may have had some of these challenges. There's certain toxins that researchers have found, and also, there's a higher risk for older parents. 1 in 54 children have ASD, and it's really detected about 18 months. Again, we're looking at developmental, domains and what a child at 18 months is able to do and what a child with ASD is having challenges. But most of the diagnoses, or 17% of the diagnoses, occur at age 3 to 17 years old. Because that's where they start to get into preschool and schooling, and this is where some of those differences get noticed. And similar to kids with ADHD, boys with autism spectrum disorder are also more common. This is a diagnosis that's more common in boys than it is in girls. So another big umbrella, of disability under neurodiversity is learning disabilities. And again, this has many different factors as what leads to learning disabilities, but basically there's a alteration in the brain, how it functions and how it's processing information related to learning. And so what, this is commonly a misunderstood term, the learning disability. Kids with learning disabilities actually have average to above average intelligence. So their ability is high, but what's happening is that there's a significant gap between where their ability is and where they're actually achieving. So their actual achievement might be way down here, and their ability is high. So there's a significant gap between that. And that's what a learning disability is, because if they have an ability here, they should be really performing, their actual achievement should be really around this area, but it's not. There's a significant difference. And so this is often also termed as a hidden disability, because it's often recognized once kids enter the school, right? It's around the reading, the writing, the math, the processing auditory information that's coming in. And this is where often it gets noticed, and at times it doesn't. There are adults who, are not fortunate enough, or even teens until later on when they get diagnosed, that there was actually a learning challenge. And again, under the umbrella of learning disabilities, there are about 13 categories of disabilities in the federal law under the Individuals for Disability and Education Act that's acknowledged. Those are the 13 disabilities. I'm not going to name all of them here, but some that you see here are dyslexia, dyscalculia, and I'll talk a little bit about what each mean, and dysgraphia. There's oral and written, there's specific reading comprehension, so a wide range of things that get covered under that. But basically the understanding is that these challenges impact the student's ability to learn and demonstrate that they can actually learn. And so just some of the ones that I want to share here: dyslexia. It affects word recognition and being able to decode and spelling. So these are kids who may actually love to read, but struggle and at some point get discouraged with it or spelling. They're reversing letters. They're reversing letters when they're reading or even when they're writing. So you notice that kids with dyslexia, the spelling is a challenge for them. Dyscalculia really affects the ability of a child to understand and learn numbers and math facts and concepts. And it doesn't mean that they cannot learn. It means that they need to learn it in a different way. So this is, I often talk to kids around a learning challenge really means I need to learn it differently. That's what it means. And so the teacher needs to teach it to me in maybe in a different way. And dysgraphia really affects handwriting and the ability and then fine motor skills. So, you'll see letters that are kind of all over the place. Some are large, some are small, so it's really the challenges with, the performance around this. And it can actually also then affect output in terms of what the child is in writing and how much they have. There's oral and written language disorders, the ability to express oneself orally or written. Kids can have a lot of great ideas, but once you say, okay, now put it down in a paragraph, could really get frustrated or even fall apart or refuse to do it because it just becomes so challenging. And it's not because, so when a parent might come in or a teacher might say they're behaving in an oppositional way, they're not producing the work. This is where often digging deeper, you might discover that, wow, they might have a challenge around the written language. So they can come up with great ideas, but trying to put it in writing is really a significant challenge, and they need to learn it in a different way to put that out. As is with specific reading comprehension. So reading, but not being able to ascertain the gist of the story, so kind of having the view forest for the trees, not able to do that. And so there are some other challenges or just learning disabilities that are not included under the specific 13 categories, domains, and they're also not included in the diagnostic and statistical manual, which clinicians use to see whether they meet the criteria or not. And some of these are dyspraxia, nonverbal learning challenges. So these are kiddos who have, again, very high verbal output and visual, but with their, they have some challenges around word, challenges around processing, working memory challenges, and then also processing speed slower. The other area that I wanted to really talk about is the executive function. So what is executive function? These are the frontal lobes that really help us to plan things out, organize, get started, keep track of the timing of when things are done. It's allowed us to focus and sustain attention, keep going and complete the task, and monitor our behavior, our emotions, and the working memory. Often kids with ADHD or who are on the autism spectrum or learning challenges can also exhibit executive functioning challenges in these areas, which could make then schooling excessively even harder. And so they need a lot of support around that executive functioning challenges. And I see this more of as a deficit in skill sets that could be. So I work a lot with parents and teachers to kind of help them teach. How do we help this student really start to develop those skills and learn it? What are the supports that can be done at home and school around? So if you're concerned about your child, what to do? The first thing I always let parents know is you're the first teacher for your child, and they're lifelong teachers. So while they go to school, they'll have coaches, they'll have different things that they'll go to. You're their lifelong coach, coaches and teachers, and you're their lifelong advocate. And so you're the expert, on your child and their behavior. You understand it really well in terms of when they get frustrated, what are the triggers when they get frustrated, when they feel nervous, when they feel excited. You really understand your child in the context when those feelings come up. So it's really important then at the beginning of each school year to really connect with your child's teachers, to really help them understand who your child is, what their strengths are, but also what are some of the challenges in the context that they may be coming up. Asking your teachers, what are some of the things that I can then use, some strategies at home to help support, whether if it's a frustration around math or about writing, about reading, whatever it is, getting ideas from the teachers around how you could do it. I would also be keeping a daily log, because you may be noticing, my child does amazing at reading and writing, but I notice that there's consistent challenges with math. And now they're getting frustrated and they're having a really hard time. So that kind of a log will really help you to figure out where are the areas that I really need to prioritize around what are the challenges that my child is having, so that when I'm meeting with the school or with the teachers or the learning specialists, where do we focus on first? Because if there's 3 or 4 things, what are the areas that are the significantly most challenging? And requesting for an assessment and getting supports. And that that's really important. So there are 2 kind of broad areas of support when we're asking and looking into the school. So one is really asking for an accommodation plan. And that's when a child is having a hard time, for example, with sustaining attention. Maybe they're moving around a lot. Maybe there's something around the challenge that they're having that's impacting them accessing their learning in academics or organization or just social. And so the accommodations in general are more global accommodations that are focused around that. And this is meeting with the teachers. Usually there's, a learning specialist and, the school principal or the head of the school sits in with the parents to determine what accommodations would fit, the child, that would support them in their learning. And this is usually reviewed yearly, but I often encourage parents to, always ask for a meeting if you're noticing, they're made gains or they need additional supports in different areas, because it's an ongoing communication with the team. Now, an individual education plan, really students have to demonstrate significant learning challenges. And under the IDA law, again, there's 13 that are recognized. And before a child can receive an IEP supports or individual education support, an assessment needs to be done. And so for kids in public school, a request is made, and within 15 working days, the school needs to respond. It's either yes, we're giving the assessment, or no, and the reasons why not. And so in a private school, families have several different options. They either can go to a private neuropsychologist to get this assessment done to figure out what are the significant learning challenges and recommendations. The other option is, even though your child might be in a private school, you would go to the school of, of the city where you reside, so where you live in. So for example, if you live in Oakland, this is the school district that you would go to ask for an IEP assessment, even though your child may be attending school in Berkeley. And so the school would then be required to either, again, say, yes, we're going to assess, or not. And if they meet the criteria for a significant disability, then they develop specific, measurable, achievable goals that are time limited. So they review that yearly. And again, you can ask for reviews more than just yearly. And here, again, even though your child goes to a private school, the public school district in the city that you reside in still is held accountable to providing some of those services, but they decide, A, if they meet the criteria, and B, what kinds of services. So that's one option. Another option, would be to check in with your own school to see the private school that your child attends, how much of these, intensive interventions would they be able to provide? Are they set up to provide? And if so, then that's what they would be doing. And if not, parents are then also looking at outside experts around educational therapists who really then work on those specific interventions around whether it's reading and writing, speech, whatever it may be that the child needs. So those are kind of in general the different ways to go. Is it an accommodation or really an IEP assessment and specific interventions that are needed to be given? And so before you can advocate for your child, the most important is to slow down and check in with yourself and say, what are your own feelings towards your child's neurodiversity? So processing your own feelings towards your child's neurodiversity is really important. Whether it's sadness, whether it's anxiety, whether it's guilt, needs to be processed and dealt with so that you could step up and move forward. Otherwise, it is going to impact the way you are reaching out and whether you reach out for support or not. And aside from processing, the next step is really being able to accept your child's neurodiversity, but also to acknowledge all their possibilities. So parenting from a place of possibilities as opposed to fear, because they have many amazing assets. And so it also requires having a conversation with your child. A lot of, some of the parents I work with are really afraid of sharing the child's neurodiversity diagnosis with their child for the fear of labeling them. And the child is experiencing things in the school. They're recognizing, I'm having a hard time in comparison to my classmates, or this is a problem, it keeps coming up. And if there is no explanation, they get to start to make their own conclusion. I'm not smart enough. I'm not good enough. I can't do this. And so when there are conversations and formal, gradual, multiple conversations that are had, the child begins to understand themselves. And that is liberating. And that also helps them to actually stay motivated, to say that I learn differently and here's how I need to learn. And that they can actually then take this forward in the middle school, high school, and college and beyond in adult work life to begin to advocate for themselves. And that's where we want to be. So when we're talking about our aspirations for our children. And it's also a place to kind of say you're not alone. It's important to find your own support community for yourself and your child. But it's also important to help your child recognize, maybe a child with ADHD also has a parent. So it's important to talk about that, or maybe a cousin or a grandfather. It's important to also recognize that there are peers in school who also have maybe similar or different challenges. So they have strengths and challenges. And that begins to normalize some of that, as well as who are some famous people, who are successful, whether it's, professional sports players, whether it's actors and actresses, or our Lieutenant Governor Newsom, who has dyslexia, but he's very successful. So it's really allowing children to see that and normalizing it in that way. And finally, I know I'm running, on time. We want to look at evidence-based treatment. And here I've looked at it in terms of ADHD, Asperger's, and learning disabilities. It's really important to look at what is, evidence-based treatment for that particular neurodiverse diagnosis. So for ADHD, there's about 50 years of research that's shown that medication is the most important thing around managing symptoms of ADHD. Behavioral management training, teaching parents around different techniques of raising their neurodiverse child is really important. And as well as school accommodations, social skills group, individual therapy is also needed from time to time, especially if the child is having anxiety, experiencing depression, or something else. They need that part to be dealt with as well. There's study skills, or tutors that may be needed to become on board. But I'm not going to go through all of it in the interest of time. So let me just kind of say, your child's support team definitely includes him or her. It includes you as a parent, and it includes the teachers and the special education service provider in the school, the learning specialist. It includes maybe perhaps a clinician who's working on some of the other areas, and maybe a psychiatrist who's on board if there's medication that's needed. And it may be an occupational therapist or a physical therapist. So you have to kind of look at who the team is, and the team all working together to support your child. Because there's that famous saying that it takes a village to raise a child. Well, it takes a support team to, really help a child with neurodiversity to do well, and they do well, but support is needed. And I'm sorry I've gone over time and we've gone really quickly, but I'm going to give it to Carla now. I'll look at questions.
Thank you so much, Dr. Sami, for a wonderful presentation. If anyone has any questions for Dr. Sami, you can just drop them in the chat and then we'll be able to redirect them. So we have our first.
I'm just going to turn on the light here. I just realized my light's off. Okay.
So we already have a couple of questions coming in. A first one would be, who should perform the assessment for ADHD? Who would be the person?
ADHD, usually a clinician does that, a psychologist. Sometimes families also go to their pediatrician. Or sometimes if there's, in addition to ADHD, if there's a question around other challenges, whether it's a learning challenge, then if there's a learning challenge that there's also part of that ADHD that you're thinking, then for that, it's really a neuropsychologist. And the neuropsychologist really assesses for cognitive abilities, the performance, the different areas, really in a magnifying way to understand the strengths and challenges to be able to see if there is a learning difference that's there to help, and then has specific recommendations. If the concern is just ADHD, clinician or a pediatrician can do that, but it's really important to make sure, it's assessed by looking at home, school, and other places, getting everybody to give the feedback and really assessing it in that comprehensive way.
All right, so another question we have, is it true that if there is a diagnosis for ADHD, does it have to be managed by medication before the child can be referred for assessment for ASD?
I'm not familiar with that. There are children who are already diagnosed with, let's say, ADHD and are receiving even medication, but then there's also another additional concern. So there is an overlap with a percentage of kids who have autism spectrum disorder. There are, I think, about 7% who also children with ADHD, about 7% of that co-occurring condition is autism spectrum disorder. So just because you're medicating the ADHD symptoms, it does not mean you will not see, the neuropsychologist will not be able to assess the, for autism spectrum.
And who should they go to if they're thinking about medication for ADHD? Should they consult with the child psychiatrist or with just the general pediatrician?
Again, this is where, with the resources that parents have available to them. Often, for a child psychologist, a psychiatrist, a child adolescent psychiatrist, that's really their bread and butter. And that's their focus, and they do that very well. Again, it's what's financially feasible. Sometimes families do start with a pediatrician, but with medication, they always start with the lowest dose and go up slowly. So they start slow and they start low and they move up slowly. And if that doesn't work, then they move to another class of medication. So usually pediatricians can also start with that, but if there are different challenges, then a child psychiatrist is really the best person to go to.
Thank you. So the next question is, the teacher suspects that my child might have dyslexia. Due to COVID, I have had a hard time finding a therapist or institution who can do an assessment to understand the severity of it. They're asking if there is a learning specialist at EB that they should be working with.
So for, dyslexia, even if you are working with a learning specialist at EB, it would still be important to get that assessment done. And I know with COVID, all of us went online like this. But in the past several months, there have been neuropsychologists who are actually seeing kids in person to do the assessment in a very safe way. So they have shields, they do all the different precautions, and they have made sure they've gotten vaccinated. So they're doing all the different precautions to actually, see the child. And for time to time, there may be actually a backlog, maybe meaning like in a couple of months, I have an appointment. And so what I can do is, Sarah, who's one of the parent volunteers who's helping to host this, I'm more than happy to send her a list of child psychiatrists, as well as neuropsychologists and educational therapists that I've worked with, and I know them as part of my network. So if you guys have those kinds of questions and want to connect with them, you can feel free to.
And I'm more than happy to also help out if any parents have any questions. I'm not the learning specialist at EB, but I am the lower school counselor, and I am also helping. We also have a reference list, and if to be able to organize, we've been working with Berkeley Unified also to be able to understand whether Berkeley Unified will be able to make an assessment or not. So we can help connect the families to Berkeley Unified if necessary. So the next question is, at what age a student can be assessed? Can a student be assessed before the age of 6?
And I'm not sure if they mean assessed for ADHD or assessed for learning challenges or assessed for autism spectrum. But for autism spectrum, for example, at 18 months, you can kind of start to see it, and kids anywhere between the ages of 3 to 17 get assessed. So there's specific, challenges that are actually seen that are significant enough that the assessment can be done. For ADHD, usually, parents, when they finally do have their child assessed, maybe it might be at, first grade or kindergarten, but they will say, I had a sense, given the energy level, and I compared it with my other child, their energy level was enormous, or this was, different. And they could have, sensed at age 3, maybe that there was some differences. And again, this is where the parents really know their children best. And the reason, usually clinicians wait about, kindergarten to first grade is, or even, second grade, but I wouldn't wait longer than that. So I would really, see if there's a concern. It's always good to go to the pediatrician kind of as a first place if it's, your child is really young. But if it's consistent, first grade, it's really time is of the essence, because you want to get lots of supports packed in there for yourself and also for your child. That's the concern.
Thank you. So our next question is, where and how can parents get like behavioral support training to be able to support their neurodiverse child?
So there are many different places. I know when I work with families, yes. So when I work with the families, who have children diagnosed with ADHD, I not only work with their child, but I work, regularly with the parents as well. So I do that. I know some colleagues who also do that. There's also a place at UCSF. Oh goodness, I'm just going to say PALS, but that might be the wrong acronym. So they provide a lot of parent training program. UC Berkeley Psychology Clinic used to do a parent training program. I'm not sure if they're still doing it, but there's different places that offer that kind of a training.
Thank you.
And I can help share some of that information with Carla once I meet with her to see, if she needs more of that information. I'd be more than happy to share.
Perfect. Thank you. The next question is, what do you recommend as best methods to connect your support team so that everyone is on the same page and sharing learnings? Would it be periodic meetings, email chains, or something else?
Usually, so that communication is really important. So especially if your child, you know, has a learning specialist, whether it's in the school or outside of school, and maybe, you know, they also have a clinician that's working with the family, and maybe if there's also medication management that's on board, it really becomes important to do that. So I think for the parents, it'd be important to check in to see, you know, if the clinician who's working with him could help to kind of, you know, manage that. And if not, is it, you know, who could do that? And sometimes the parents themselves are having to actually then manage. You know, I usually like the once a month or every other month meeting with the overall team, if possible. And if not, I'm usually connecting with the different team members separately to make sure we're all on the same, you know, track with this. But usually having a team meeting just for all the providers to connect and kind of talk, that's important.
Right. Thank you. So our next question is, how might we address parents who respond possibly with some avoidance, right? That might be having some difficulty accepting some of the suggestions that might be coming from the teachers or school that their child might be benefit from an assessment.
So I would say, you know, a place to start is always talking about the strengths of their child, and pulling parents to talk about their own strengths that they see for their child. That's always a good place to start. And then moving the conversation of what are some of the challenges that you're seeing. You know, I think the place where teachers are helpful is, you know, for families, sometimes it's their only child, or sometimes they have other children as well, but there's not enough of a sample pool to base our responses on. So teachers, you know, have taught for many years and many students, and they can start to pick up that, you know, so-and-so needs this kind of a support. I would say also maybe providing some specific kinds of support strategies, so that, you know, the parent can see what that is, you know, as a, or encouraging the parent to actually have it assessed just to see if anything is there that would then give the teacher helpful feedback in terms of maybe, you know, what other additional learning strategies to incorporate. So, you know, I think a lot of times coming from an inviting place would be helpful, but it's hard for parents to acknowledge that, and if they have not acknowledged it earlier on.
Thank you. So this next question is, how do we distinguish between a child who is just showing high activity versus an actual being actually neurodiverse, right? And I guess this then ties into a second part of the question is, why is there a lower percentage of children diagnosed with ADHD in other countries versus the United States?
You know, that's a great question. So it's a two-part question. I'll try to answer the first one and then the second part. The first part, absolutely. That's why it's important to get a comprehensive assessment. So this is why it's important to kind of meet with the family to really hear and understand what are the symptoms, the duration, you know, so that it's not, you know, confounded with something else that's going on. This is where, you know, comprehensive assessment really helps with that, because that clinician or the neuropsychologist, depending on who you're going to, is really looking at it. What are the specific symptoms? When did it come up? How long has it been going on? Let's look at the severity. And it's looking across settings. It's not just looking at home or school. Sometimes I work with kids who are not behaving in the way they're supposed to in the classroom setting, but when I'm meeting with the parents, they're not seeing that there. So for me, that makes me wonder what's happening there. Is it a learning challenge? Is there frustration? What's going on? So this is where they're looking across setting. And you're also looking at the level of impairment that it's causing. Significant impairment, whether it's with peer relationships or academically or within the family. And so if those could be found out and assessed, and then supports put in place, that child is actually receiving help much quicker to move forward and do well. Now, why is this in other, you know, the prevalence rate is about similar in other countries as well. I don't know if you might be thinking about the medication piece where maybe in the US it's higher than other places. I think part of it is, you know, we are able to actually, given the knowledge, we're able to actually catch it much quicker and faster, and we have more ways of assessing it. So that could be another way. And maybe that the teachers now are getting really, you know, training as part of their teacher training to pick up on those things so that they are able to support the family and say, hey, this is what's happening. You know, I've worked with lots of families when they're coming in and we're assessing, and as I'm talking about the symptoms, a parent is sitting and saying, that sounds like me. And I know nobody, and the frustration that they grew up with and that they actually never received that help. So I think being able to go to someone to see if that's a concern, at least if nothing else, it, you know, helps to lay that concern to rest.
So we have one last question so far, and it says, so how does ADHD possibly influence or affect abstract thinking? And how do we help develop it if that's the case?
Well, kids with ADHD in general, overall, are amazing creative thinkers. They can notice details. They are, you know, they can come up with great ideas really quickly. You know, so that part for them, it's amazing. They notice little details. They can come up with, you know, different fantastic, amazing ideas faster. They're innovative. They can, you know, think of different ways of creating stuff. And so that's a strength for them. And, you know, I think the flip side, the challenge maybe is sometimes when I'm working with families and I see that, you know, they have so many great ideas, it's really hard to kind of, you know, sort through it or organize it and then kind of create a timeline to follow through with it. And I think a lot of this would be helpful, just, you know, working with an educational therapist or what we call an executive functioning coach to kind of help. How do you help them slow down? How do you help them plan? How do you help them kind of moving forward on those, you know, the great invention that they're thinking about, taking those small steps forward? And, you know, because when things become effortful, it's more likely that they'll say, I'm kind of tired of it right now. I don't want to keep pursuing it. So that's where an executive functioning coach will really help them to develop those skills more. And so that they can be successful, not only in school, but later in life.
So we actually have one last one, I think, to be able to wrap up because it is 8 o'clock. And the last one is, what is the difference between an IEP and a 504? And I know that you touched a little bit about this. And which one would be more appropriate for a child with a diagnosis of dyslexia and ADHD?
So if a child just has, you know, the difference is an accommodation plan really basically says there are going to be things that are done within the classroom to accommodate for a child, for example, ADHD, if they just have specifically ADHD. So they may be seated up more up front. They may be, you know, not a lot of distractions around. They would be given frequent energy brain breaks so that they can then sustain attention and come back and focus. There may be that, you know, once a teacher is done with instructing, they may go to that, you know, student and say, do you understand what you need to do? What's the next step? You tell me back. So checking for understanding. Those are all accommodations. And basically an accommodation means the teacher is having to do something somewhat different for that particular student within the classroom in order to make sure that they are accessing the learning. Now, with a child with, let's say, a learning challenge like dyslexia, that requires an IEP, an individual education plan, because that may be resulting in a significant difference in performance. So their performance is really, I know in elementary school, they don't do grades, so it's below grade level. So if you're noticing that your child is consistently earning below grade level in a particular activity or subject, that's, you know, and now you're in year 2 or third grade and you're still seeing that consistent piece, it's really important to get that assessed. And that's an IEP assessment to see if there's actually is a significant learning difference, and that would require more one-on-one intervention. So that way the child is either pulled out of class for that intervention, or someone comes in, or there's a special class during the day that they go to get that special specific learning techniques done, so that they really understand that piece.
Thank you so much, Dr. Sami.
Sure. Thank you again for having me. I know it's getting late in the evening. Gosh, you guys have such an amazing resource in the family support group, the Learning Difference support group. What a great asset. And what a great learning place and supportive community that I shared. That's important.
Thank you. Thank you, Dr. Nilofar,
us
and
to
thank you
have.
for giving
you.
such a thoughtful and thorough
So thank you so much.
presentation and answering every question. And thank you also for telling everybody about the Learning Difference support group. For all of you who aren't familiar with that, contact myself, Greg Nemitz, or Sarah Sawyer. We have regular meetings. We have a Google Doc where we share resources, and we'll also share a link to this presentation if you want to watch it again. And once again, thank you. Great presentation. Thank you all for coming, and have a wonderful evening.